Hello and welcome to the musculoskeletal ultrasound section of SonoWorld. I am Dr. Tony Bufar from Henry Ford Hospital in Midtown Detroit, Michigan. Of course, that's in the United States. For the next half hour, I'll be talking about the adult hip and how to begin a routine exploration and try to show representative examples. And from there, I hope you can use it to your advantage. And once more, welcome to the world of musculoskeletal ultrasonography. For the ultrasonography of the adult hip, it would be best to begin by talking a little bit about technique and anatomy of the hip. From there, we're going to talk about the most common indications of ultrasonography of the hip. We begin by taking a look at the most common indication, which is going to be the effusive joint, followed by some bursal lesions, and then because of the center that we're involved with and much more of orthopedic radiology, we're going to look at some traumatic cases. Today's world definitely shows that there's a lot of joint replacement, and therefore it is inevitable that we talk about ultrasonography of the prosthetic hip. For the ultrasonography of the adult hip, one has to develop the technique and have a knowledge of the anatomy of this joint. So here we see a frontal view of the normal hip. Note again that this one has the capsule over it. And once you have the colored image, try to remember that you look at images both on end-on or face-on if you wish. We like to say sometimes en face. And then a profile, as you can see on the right-hand side. So on profile, albeit that the hip is covered by the fibrous tissue of the capsule, you begin to imagine again that you have to look at images on orthogonal planes, both in gross anatomy and of course in grayscale imaging. So let's begin by looking at the adult hip on grayscale imaging of ultrasound in the long axis view from the femoral head to the femoral neck. Let us look from the caudal or inferior portion, wherein you have the diaphysis of the femur and the tubercle of the, in this case of course, the lesser tuberosity, as you look at the intertrochanteric ridge, and then into the femoral neck proper. Then at the transition between the femoral neck proper and the convexity of the femoral head, you have the subcapital line. As you go cranially now, you approach a signal void or echo void here, representing the joint space, and finally you get to see the bony acoustic landmark of the acetabulum. Over the acetabulum, with a little bit of hypoechoic hyaline cartilage undercutting, you see the hyperechoic triangle of the acetabular labrum. Continuing inferiorly now, you note that there is the relatively thick capsule, okay? And here you could appreciate the volume of this capsule. Over that, you begin to appreciate the multipennate structure of the iliopsoas muscle. So while everybody is familiar with color images of gross anatomy, we're now going to proceed in talking about the grayscale imaging. Note too that when we look at the adult hip, more often than not, we're using the curvy linear array transducer for the depth that's involved in looking at this hip joint. And if you look at the normal hip in the long axis view, you're now familiar with the skyline pattern or the silhouette in this profile. But it is not until you look at it also on short axis view. So you're now familiar with the hip in long axis view, and now we turn the probe in 90 degrees to look at it in its orthogonal plane. Once you do that, you note the convexity of the femoral head and of the left hip in this case, and of course over that you see the hyperechoic triangle one more time of the acetabular labrum. On top of that, you'll see the mixed pattern and echo signature of the styrene pattern of the iliopsoas muscle and iliopsoas tendon. And so here, therefore, one begins to appreciate the fact that all imaging must be done in orthogonal planes. It is not uncommon for us to turn slightly oblique in order to elongate the runway or the perspective of the femoral neck. As a matter of fact, when we do interventional approaches to the hip, we like this type of approach because it lengthens the runway, and so our target's a bit longer. So aside from a strict short axis view, as you can see on the right hand side, try to remember that you can also slightly oblique the transducer in order to accentuate any or all parts of the subcapital portion of the hip. The normal hip, as you can see here in a representation of the pelvis in AP view, you could now appreciate the fact that you have to go from a level of the acetabulum into the iliac fossa. This is important because of the proximity and contiguity of the hip into the iliac fossa. Case in point, for example, everybody knows that the iliopsoas bursa can itself ascend into the ipsilateral-iliac fossa. So here in grayscale imaging, you can appreciate the bone acoustic landmark of the inner portion of the iliac or innominate bone. And as you could now notice that at the level of the higher portion of the iliac bowl, you now see the hypoechoic psoas muscle, or iliacus in this case, and of course the musculotendinous junction of the iliopsoas proper of the left hip and pelvis. So if you have familiarized yourself with the anatomy of the hip, it's now time to look at some of the uses of hip ultrasound in your patient. Let's begin again by looking at something in long axis view, and that means it's going to be in profile for the hip. Of course, most commonly, and all of us have rehearsed how to look at the effusive hip joint in the anterior approach only. So the collection of fluid will definitely be shown as it distends the capsule, as you can see here, a schematic drawing superimposed on a black and white image of the colored images I showed you earlier. But please do not forget that fluid loves to gravitate, and therefore it could pool into the posterior or inferior portion as shown here by the number 2. So you must position the patient in such a way that after you've addressed the anterior portion or the anterior capsule, that you'd like to check the posterior region. In doing so, when you look for hip effusion, a left-right comparison is important. Case in point, for example, we already have seen the normal left hip in the normal anatomy we just addressed. And everybody remembers the silhouette of the acetabulum, acetabular labrum, convexity of the femoral head, the subcapital neck part, and the proper neck portion of the femur, and finally into the intertrochanteric region. And of course, the non-distended capsule subjacent to the iliopsoas muscle. In the affected hip, immediately over the acetabulum, femur, and femoral neck, you'll notice a distended capsule, and within it some mixed echogenic pattern representing an effusion. So left-right comparison is essential, especially when you address it to the non-imagers like your referring physicians or emergency room physicians. So once you are familiar with distension of the capsule, we can now begin to show some cases. This elderly gentleman comes in with pain and fever, and you do not even have to address or even hint at which hip is going to be affected. Point is, you're going to do a left-right comparison. But first, let's look at the radiographs. As you can see, of course, there already is joint space narrowing of the right hip. Let's go back to the initial examination or radiograph and recall that there is a great difference between the degree of the joint space on the asymptomatic left and the affected right. So here you see a dedicated view of the right hip, confirming indeed that there is joint space narrowing, and you could even get a hint that there is a little bit of distension of the gluteal outline and the iliopsoas outline on this cone-down view of the radiograph. It's not uncommon to immediately ask for an MRI if it's an emergent type of reason. And here you can see on a proton density coronal image that there is some signal void in the subchondral region representing fluid or contusion. Again, you could appreciate probably less than the radiograph, but still to some degree the joint space narrowing on MR. And of course, once you use the fluid sensitive T2 sequence, obviously now you begin to appreciate not only the subchondral edema we talked about of the femoral head, but also that affecting the acetabular region, plus the distension of the capsule by fluid, probably very little, much less appreciated on the proton density coronal images. Of course, immediately if you were to plant a probe in this individual, right off the bat, you could see in the long axis view here the silhouette of the acetabulum and the femur, the distended capsule, and perifocal to it would be some neovascularity in a Doppler positive hip, meaning that there is some indeed inflammation occurring in this individuals. This is the right hip. So now we're going to rotate the probe counterclockwise, and we're going to look at a plane at the level of the femoral neck. And when you do that, as you appreciated on the long axis view, note that on the short axis view, the markedly distended capsule in the subfemoral region, confirmation of the effusive hip at this point. Very simply, therefore, still in the short axis view of the right hip, you can introduce a needle, as shown here by this high-level linear echo. And to accentuate that, it is not uncommon for us to apply power Doppler in order to see not only the extent but also the direction of the needle. So with power Doppler, therefore, it helps us to immediately visualize the needle, and not only the shaft of the needle but the very tip of the bevel, in order to be clearly positive that we're within sampling area of the hip. This is a video clip available on the EULAR website, and this is Dr. Johan Koski from Finland, and this is the approach that most of us will take. Note that he will park the probe more or less in a compromised long axis, short axis view to get a longer runway of the femoral neck, and that he likes to visualize the shaft of the needle in the long axis view, which is the same way we practice in our institution. Here on the grayscale imaging in real time, notice that the needle is introduced, and as it approaches the capsule, you jab it in, and then you get to see the very tip and bevel of the needle in this distended hip joint. Okay, so this is a very easy approach, and to date, therefore, we never try to stick a joint blindly. We always almost use ultrasound guided approaches in these individuals. In hip effusion, like we told you earlier, that a left-right comparison is necessary. And here, case in point, for example, on the abnormal side, you'll see a distended capsule, while on the unaffected opposite side, you notice that it's still downsloping and uninvolved. But as you look at the distended capsule a little bit more closely as you make a left-right sweep, or as you pan or zigzag through the hip joint, you'll notice that inside the capsule there are some punctate high-level echoes. These high-level echoes eventually on radiographs are confirmed to be radio densities on this frog leg radiograph, and on a coronal image proton density you will see that there is indeed distension of the capsule by uncomplicated fluid. On the actual images at the level of the femoral neck, you'll notice not only the distended capsule but also some synovitis involved. But yet, as you look a little bit closer on the T2 image here on axial, you'll notice these signal voids representing synovial chondromatosis. So it is important, after you have looked at the fluid in any effusion, especially in the hip, to further characterize it if there's going to be some high-level punctate echoes, in this case representing the innumerable loose bodies of synovial chondromatosis versus synovitis. Let's now look at another case wherein the individual comes in with hip pain and effusion. One more time, until we identify it on ultrasound or sometimes on radiographs, we probably wouldn't guess right away which hip is involved. But once we ask the patient to continue with another frontal view, cone down view, accompanied by a frog leg lateral view, we appreciate that in the translation from the AP view to the frog leg lateral view, there's a persistent radiopaque density at the lateral aspect of the subcapital joint. And this loose body now is readily confirmed in the long axis view on ultrasound when you see that between the bony acoustic landmark of the acetabulum and the convexity of the femoral head, you see the curvilinear high-level echo in between the two structures plus distending the capsule, confirming indeed that this is a loose body. On a more superficial scan, again, confirmation indeed that it is between the acetabulum femoral head distending the capsule of this loose body within the hip joint. So not only can we see synovial chondromatosis with innumerable high-level loose bodies, high-level echo loose bodies, but also a single loose body in people with a loose body in the hip joint. Of course, if you do a left-right comparison, you begin to appreciate this immediately. Case in point, for example, we already saw that in the long axis view, we saw this high-level curvilinear echo in the distended capsule of the right hip, and immediately when you show it on the left-hand side, you begin to see the great difference between the two, readily convincing a novice or non-imager that indeed it's a unilateral loose body in this hip. In another patient, as we look at sequential planes of a T2 coronal image of the hip, you'll notice that at the plane of the sacrum or sacroiliac joint, as we proceed from posterior cutting into the anterior portion, we now get to see that there's asymmetry between the two hip joints, and probably best appreciated as probably the last two sections here, wherein you could see that there is a collection of abnormal intensity and signal aberration on the right hip. If you look at that, therefore, you are approaching your visually the right posterior hip in this individual. We could readily detect the bony acoustic landmark of the posterior acetabulum and an abnormal collection of mixed tissue right posterior or immediately posterior to it. So on ultrasound, therefore, this is what you're going to see. But first, since we already oriented you on MRI, let's again start with that. Already we were pointing out that there is increased signal aberration asymmetrically affecting the right hip. Here, for example, the same fluid collection that you can appreciate and see on MRI is readily seen on the same coronal view on ultrasound. And this is the posterior approach. This is why, although anterior approach is probably easier, do not forget to look at the posterior hip. And here you begin to note that there is a hypoechoic collection of fluids surrounded by a rind of soft tissue representing this abnormality on a, if you wish, a long axis view and then on a short axis view, again giving you that orthogonal orientation and triangulation that you'll need as an imager. Once you've identified that, we'll stay on the axial view, and again you have your target listed here and visualized as hypoechoic lesion. All you need to do now is introduce a needle, and very clearly you could see the entire shaft of the needle. But not only that, but also there's a bevel in the tip of the needle, to the point that you can even see that it is a bevel up, that the bevel is directed superiorly, or at least in this case anteriorly, in order to sample correctly this posterior hip effusion. In this individual, of course, the most common bug that we've been cultivating in our center is going to be Staphylococcus aureus. So ultrasound not only confirmed that there was abnormal effusion, but also helped us direct the needle exactly to the sampling that we needed. Let's move on to the multiple bursae of the hip, and this is going to be important. The definition of a bursa is a small purse or bag in Latin, and wineskin or hide, but animal hide in Greek. There are more than the three bursas that we're going to talk about the hip, but let's concentrate on the iliopsoas, trochanteric bursa, and the ischiogluteal bursa. In a schematic drawing, we're going to show first the more common greater trochanteric bursa on the lateral aspect, usually draped over the greater trochanter. And then the least common is going to be the ischio-gluteal bursa, located just over the posterior tubercle of the ischium. And the drastically more common iliopsoas bursa, sometimes confused as an abscess, but also remember that this one likes to ascend into the iliac fossa, is going to be the iliopsoas bursa. In a sagittal view of this, on the axial view, you could appreciate the iliopsoas bursa jutting out of the femoral head in between the iliopsoas and the pectineus, but remember that it's clearly adjacent to the great vessels. So this same bursa would like to ascend into the iliac fossa. On the coronal view, the iliopsoas bursa again starts at the iliopsoas junction and insertion on the lesser trochanter, and it likes to occur in between them, but notice that it's going to go over the ilioinguinal ligament and deposit itself over the iliac fossa. Suffice to say, therefore, that it is on the medial aspect of the hip and within the proximity of the great vessels. Here on the left hip of a patient, on a T2 axial view of the hip, you'll notice the femoral head and then the acetabular fossa. Here on the anterior pillar of the acetabulum against the femoral head is a distended collection of signal aberration that represents the bursa. Note that it is in the proximity not only of the great vessels but also of the iliopsoas tendon. This pulsatile mass that was present for a whole month is seen on ultrasound as a hypoechoic lesion. However, notice that you can't tell what's going to be the bursitis or cyst, if you wish, against what is going to be great vessels. With ultrasound, one of the great advantages is that you have Doppler. In this case, of course, color Doppler angiography confirms that the upper portion of the hypoechoic abnormality were the great vessels, and the lower portion was the bursa. This is a case presented to us by Dr. Kil-Ho Cho from Daegu, South Korea. Now, if we take a look at this bursitis, notice how it likes to elevate itself out of the joint into the iliac fossa. Likewise, the size of these bursitis can be pretty monumental. So one more time, in the long axis view, you can identify immediately the femoral head against the acetabulum. And initially, when you put your probe down, you'll notice that it's very difficult to delineate what's going to be the sac or bursitis, the cystic appearance, against what's going to be great vessels. Many of us, of course, are very familiar with the pulsatile nature of the great vessels and probably can appreciate it on great scale. But it's not until you put a Doppler angiography that definitely now you could see that it is the great vessel that is draped over this large and monumental iliopsoas bursitis. Sometimes they may be quite small and yet approachable by needle guidance. Case in point in this example, on the right hip of the patient who's lying down, and you're looking at the patient from his feet, you'll notice that there's a heart-shaped collection of increased abnormal signal collection, should be representing fluid. Note that it's pushed the tendon to the lateral aspect on short axis view, and on axial view, these are the great vessels. Also, before you leave the MR image and look at the ultrasound image, note that if you jump from the right hip to the left hip, there's a smaller iliopsoas bursa. Again, one more time, immediately adjacent to the tendon, iliopsoas tendon, and in proximity of the great vessels. Looking at the right hip on ultrasound on short axis view, you can readily identify the bone acoustic landmark of the acetabulum and femoral head, but also the bristle pattern of the tendon. And then once you have identified that, there is a collection of hypoechogenicity in between the tendon and a second area of hypoechoic structures. clearly. If you've done that, then remember that it was going to be tendon, bursa, and vessels. So an ultrasound on a short axis view now, one more time, bony acoustic landmark of the femoral head. On top of that is the tendon of the iliopsoas, and put Doppler in because immediately you confirm that what was signal void on MR and initially echolucent now clearly were the great vessels. But what's important about this case now is you can appreciate the fact that we have clearly demarcated all the structures. Therefore, we can now thread a needle exactly to the area that we need to sample. So once you have that, you can direct under ultrasound guidance not only the direction of the shaft of the needle, but also the very tip or bevel of the needle. And in this case, it only turned out to be hydroxyapatite-induced synovitis in a patient who had prostate carcinoma. But again, one more time, sampling it under ultrasound guidance clearly gives us that after aspiration, we have a clear diagnosis, in this case, hydroxyapatite synovitis. Let's switch from the more common iliopsoas bursitis to the greater trochanteric bursa. And if you take a look at this schematic drawing, you'll notice that all segments of the gluteus muscle from the minimus to the maxima have interdigitating bursa. And what is interesting about this is that each one has its own insertion, or at least each muscle group has its own insertion into the facet of the greater trochanter. But even more interesting than that is that between every muscle group of the gluteus, you'll notice some bursa. Of course, while we call it bursitis, it's very difficult to separate what is bursitis from tendonitis. That's the schematic drawing. Here one more time, one line drawing showing clearly that the minimus, medius, and the fascia lata, or gluteus maximus, which inserts on the fascia lata, have each individual bursa. And again, for confirmation, you can go ahead and inject some barium contrast. Here you see on a C-arm image or radiography that we can inject each bursa individually and confirming the location. Here, of course, as you can see from Dunn's Clinical Anatomy in 2003, that we can fill these potential spaces with contrast on C-arm imaging. It is easy to confirm the silhouette on long axis view of the greater trochanter. And so here, for example, on the right hip, you can identify the greater trochanter and then the subtrochanteric region going into the metadiaphyses of the femur. Over that, you have not only the iliotibial band, but also insertion of the gluteal muscles. This is on the long axis view. So in patient in decubitus position, very simply, line up the transducer, identify the silhouette of not only the greater trochanter, but also a part of the lateral acetabulum, or if you wish, the ilium. Once you've done that, with a little bit of heel-toe maneuver, you can confirm the fibrillar pattern inserting into the enthesis of the greater trochanter. When affected, immediately, of course, you know that over the greater trochanter, you're going to see a distended fluid-filled sac, most likely, usually uncomplicated. But in chronic cases, of course, you'll see some intraluminal echoes within this distended sac. Let's begin by taking a short axis view of coronal, of actual MRI image in T2, and the fluid sensitive sequence tells you that around the greater trochanter, here's the femoral head, femoral neck, greater trochanter. On the medial aspect, you see the acetabular fossa. That around the greater trochanter, you have a collection of abnormal fluid distending not only from the anterior portion all the way down, all the way posteriorly to the back of the patient's hip. Very easily park your transducer, and then you see the bony acoustic landmark of the greater trochanter, and of course surrounding it you see this distended bursa around the individual. Note that you have to again look entirely all the way down, all the way back of the hip in order to confirm the extent of this disease. Now we're going to turn the probe around from the short axis view. Rotate your probe counterclockwise to look at it on long axis view. And in doing so, immediately you have already rehearsed on how to look at the long axis view of the greater trochanter, and you see the tubercle and the metadiaphysis of the femur. And what was supposed to be an imperceptible bursa and uninterrupted fibrillar insertion into the greater trochanter, now you see this markedly distended sac conformation of a trochanteric bursitis in a 50-year-old female on short axis view ultrasound, long axis view ultrasound. For confirmation, of course, you may employ MR, but it really was unnecessary. The least most common bursa in the hip is going to be the one over the ischium of the ischial tuberosity, or the tubercle of the ischial tuberosity. It is said that it's usually secondary to sitting on hard surfaces while crossing their legs, so quite common in some Asian cultures wherein people like to squat more often than not. Here from Moore's anatomy, you could see that the pressure that's going to be demanded on the ischial tuberosity as people have prolonged sitting, for example, in a chair, or if they were to squat for lengthy periods of time. And so these could be seen in vibration-related jobs such as cloth weavers, tractor drivers or those semi-drivers, and of course road equipment machines that really have sustained vibration of their equipment. Once in a while, of course, you'll notice that what is ever in industrial medicine is translated into the athletes, and we see this in canoeing and horseback riding. What we see in these individuals is a referred pain around the ischial tuberosity from the ischial bursitis. And why not? Here, while Netter's drawing shows a left hip examination, and if we do a gross anatomy look at it, you'll appreciate the fact that if you take a peek at the ischial tuberosity, that the proximity of the sciatic nerve to this area and the posterior cutaneous nerves to this tubercle and a potential and a very potential bursa is really most likely to affect all these structures. So, on MRI imaging, if you look at the left hip of an individual, let's begin by taking a peek on the fluid-sensitive T2 image. You'll notice that the unaffected ischial tuberosity on the right side, as we go over the patient's perineum onto the left side, that clearly there is a signal aberration unilateral to the left side. And as we jump to the actual imaging, patient is lying down and you're looking at the patient from his or her feet. You'll notice the left-right comparison, there's a collection of fluid. But again, if you take a sagittal view of the same individual, here's the ischial tuberosity, and this is the anterior portion of the patient, you'll notice that there's a fluid blood or fluid level. And of course, isn't it much more simple to look at it on ultrasound? Because if you do this in the long axis view, that means the top of your transducer is directed to patient's head and the bottom of your transducer, patient's feet. Not only do you confirm a distension of the bursa, but also a fluid level. But clearly, the higher level echoes that you could see is the particulate portions of blood that is gravitating to that area. So we've seen technique, anatomy, effusion, and bursitis, and now let's jump into what trauma would appear like. In chronic disease or avulsion injuries, this is what could appear. Let's first look at the asymptomatic side. On the right-hand side, you see the anterior inferior iliac spine, where the origin of the rectus femoris is. And if you jump to the affected side, you will clearly note that there is asymmetry or a lot more traffic on the affected side. So what was supposed to be a sustained fibrillar pattern of the tendon is now interrupted by this hypoechoic collection of fluid. Let's go to the short axis view. First the unaffected side, and you could see the bristle pattern of the hyperechoic tendon clearly inserting into the anterior inferior iliac spine. The affected side has not only this hypoechogenicity, but a rind of high-level echoes surrounding it without too much of a posterior acoustic shadowing. So when you do a Doppler positivity on this individual, you could see that not only does it confirm the extent of the disease, but also the acuity or recurrence of this disease. So in this same individual, therefore, if you were to take a radiograph, a frontal radiograph, in this case coned down or cropped, you'll appreciate now a high level opacity adjacent to the anterior inferior iliac spine, indeed confirming that there is an abnormality in that region. For academic sake, although it's so clearly unnecessary, let's look at the corresponding coronal view, and you'll notice that on the fluid-sensitive T2 sequence that there is increased fluid collection trickling down, but also a signal void surrounding the same rind that represented the calcification. If you look at this on actual MR images, very difficult to immediately detect the abnormality on the anatomic sequence. Here you see the femoral head, the acetabulum, the anterior inferior iliac spine. It is not until you employ the actual image on T2 sequence for the fluid sensitivity that you begin to appreciate the edema, the abnormal fluid collection, and of course the signal void representing the calcifications in front of the hip at the origin of the anterior inferior iliac spine. Once in a while, you'll be directed into some symptomatology of the adductors, or some people might think about pubalgia. So pain in the pubic symphysis area is also addressed as part of the hip exploration. Here you could see the gross anatomy of the different facets and tubercles of the lateral portion of the symphysis pubis, where you're going to see the origin of the adductor longus, brevis, and magnus. As you go from the cranial portion, as you go from the inferior portion to the cranial portion, you'll notice each individual facets and insertions of the adductors. What is going to be important here initially for the imagers who want to begin exploration of hip studies is to do a left-right comparison. So for adductor tears, for example, when you begin initially, you'll notice that the adductor longus, brevis, and magnus, and if you look at the bone acoustic landmark, you could see that there may be some interruption and edema or contusion of the longus at this point. But it's not until you do a long axis, short axis view that you'll see that there's indeed an interruption of the pennate structure of the muscles. In this case here, you see the hypoechoic defect, a measurable gap in this individual, now consisting indeed of an adductor tear. And from a short axis view, now you take a look at a long axis view. Now you can clearly see not only the retraction of the medial and lateral stumps, but also a large collection of hematoma interposed within this area. I know that it's easy for us to judge people who like work in emergency rooms, or at least for walk-in patients, and it may be quite difficult, but once in a while, be it as it may, we on radiographs may miss some fractures. Case in point, a 65-year-old female comes in with dull pain in the left hip for the past 2 weeks. While initially the radiographs were dictated as unremarkable, but it is the radiographically occult fractures that may occur. And sure enough, because it is hip pain, they might ask for an ultrasound to look for an effusive hip. Let's begin with the unaffected right side, and you already are familiar with the bone acoustic landmark of the femoral head, the subcapital region, and the femoral neck. You note here that the capsule is not distended and that the iliopsoas muscle is not splayed. If you look at the affected side, immediately you'll see a step-off deformity on ultrasound representing what should be a capsule or a spur. And if you ask for new radiographs, you'll see the sclerotic band in the subcapital region representing an undisplaced insufficiency fracture. For confirmation in an individual who already had an initially occult radiograph, you might need an MR. Suffice to say, though, that we already appreciated it and saw it on ultrasound. So here on a coronal proton density, or T1 image, you see a signal void, linear signal abnormality across the subcapital region on the left hip, very different from the contralateral right hip. Jumping from there now and asking for a fluid-sensitive sequence, not only do you see the bone marrow edema and contusion in this individual, but also the same signal void that you appreciated on T1 cutting across the subcapital region, but all corresponding to already the sonographically evident undisplaced subcapital fracture of the left hip. And as you can tell, this individual with this subcapital fracture needed 3 cannulated screws in order to have internal fixation or percutaneous fixation of this hip. So confirmation indeed that not only visually but also clinically this is a hip fracture. It is interesting that we've seen the bone acoustic landmarks in this individual, the joint space or the joint line, and not only do we see them but also the acetabular labrum. So if you look at on long axis and short axis view, you can identify the femoral heads and the acetabulum. In between them you see this hyperechoic triangle both on long axis and short axis of the acetabular labrum. This is going to be important nowadays because of the femoroacetabular impingement. So if you put your probe in, let's say, the long axis view, you may see first on the unaffected side the bone acoustic landmarks of the acetabulum and femur and a preserved triangle of the labrum. But as you jump towards the affected side, you see the bone acoustic landmark of the acetabulum and femoral head, but instead of the expected hyperechoic triangle of a labrum, now you see a disruption and a paralabral cyst occurring to this, clearly now showing acetabular labral tears. Let us end the discussion of the ultrasonography of adult hip by looking at the prosthetic joint. Here you have a patient coming in with a painful unilateral left prosthesis. On radiographs, very difficult to appreciate going on, probably except maybe an elevated calcar. But again, on ultrasound, we're going to look first for abnormal fluid, not only in the proximal portion of it, but also on the distal portions. So we're going to look at the fluid and the integrity of the pseudocapsules in these individuals. What we like to do is to look at it on long axis, and we are going to look at the prosthesis versus the native bone. Because if there's any abnormality, it's going to be between the prosthesis and the native bone. So clearly, while this is very tempting to sample between the prosthetic femoral head, femoral neck, you'll notice that maybe this is the region that we do have to address. We do like to address that because here the probe is on long axis view. Note that you'll see the metallic prosthesis. So any abnormal collection of fluid distending the pseudocapsule at the intertrochanteric ridge, at the intertrochanteric ridge is the area that we're going to take a peek at. So case in point, therefore, when an individual, a 50-year-old youngish male, comes in with painful prosthesis only 5 years after a ceramic total hip replacement, we're going to address not only the metallic portions, but also the intertrochanteric ridge. We're going to look for not only septic loosening, but also mechanical loosening and wear debris synovitis. We do this one more time by looking at it in the long axis view, and you see the reverberation artifact of the acetabulum, but much more so with the femoral neck. And like I said, while you say that this capsule may be distended, it is over the native bone that we need to look at it clearly. Here you see that there is a greater than 4 millimeter or 5 millimeter distension of that capsule. Probably better appreciated in a profile and a cross-table lateral view in this individual. So here's the acetabulum and then the metallic head and metallic neck. So you could see the reverberation artifacts of the femoral head, femoral neck. So it is this region that is of concern to us, and that's the site where most of us would sample. And then that individual, of course, would be abnormal, and of course, we need some sampling. Usually it might be infected. In the inflammatory and infections of the prosthesis and hardware, we try to look for abnormal fluids surrounding the hardware, as you can see here. Very difficult to appreciate, of course, on the radiographs. But on ultrasound, clearly, you get to see the high-level echoes with reverberation artifact of the prosthesis and abnormal fluid collecting over it. So here you see dynamic imaging, wherein now you started on long axis, and on short axis you begin to see the prosthesis and the abnormal fluid collecting over it. But maybe some of you have already appreciated some punctate high-level echoes on the left-hand side of the prosthesis. We don't know if this is gas entrapped in the synovitis or maybe some debris floating. Notice later on that while they're percolating on the dependent side, you can aspirate this same bubbles and confirmation of what's going on. Here you see a tip of a needle that was a high-level echo. Employing one more time Doppler, we accentuate the tip of the needle. Sometimes it may be in color, but definitely it's high echo at this point. Notice that the bubbles that I mentioned are percolating on the inside part, and you could suck the samples from the dependent portion to the bevel of the needle itself. Confirmation indeed that this was positive, and usually for Staphylococcus aureus infection. The sample that we get would be, again, purulent, and the different parameters that we need are definitely a gram stain, cell count, and culture, especially if the patient has not started his antibiotics. In addition, though, however, we'd like to centrifuge much of this and to look at it on polarized microscopy for any crystalline arthropathy in these individuals. For bacterial infections, as you could see in this prosthesis with chronic osteomyelitis and already a failed portion of it, notice that if you were to introduce contrast in the intracapsular portion of the acetabular femoral joint, some of it would trickle inferiorly into the distal portion. Therefore, it will behoove you to make sure that not only do you check the hip portion, but also the distal parts. Case in point, in this individual, once you could see that indeed you see the prosthesis, an abnormal collection of fluid. So anytime we see extracapsular, extra-articular, but perifocal fluid collection along the prosthesis, that for us represents bacterial infection. Here you could note that a more difficult sampling of the hip is readily sampled in the distal portion on short axis and on long axis. Already you could see that while the callus formation might be buttressing enough, there may be an elevated portion, but it is abnormal fluid collection that we would target for extra-articular collections. So another one here with a dynamic hip screw modified to take in another compression screw and multiple failed screws around it. Isn't it much simpler, instead of sampling the hip, as you could see with a pseudocapsule, to go down to the distal portion, again the high-level echoes of the prosthesis, but the abnormal collection of fluid clearly states that this is what you need to sample. So once you go from the hip all the way down to the plate, as you could see here, without any reverberation artifact, but as you proceed further caudally, inferiorly, that abnormal collection of fluid tells you that indeed this is the area that you want to sample for confirmation. Once in a while, though, you could have changes like this. Note the incongruity of the artificial femoral head against the acetabular cup. We don't know if this was a traumatic dislocation or simply wear and tear. On ultrasound, in the long axis view, you can identify the intertrochanteric ridge, the pseudocapsule, the reverberation of the femoral neck and femoral head. But lo and behold, while you may think that this is part of the acetabular component, when we do a dynamic imaging, notice that it releases, and you know that this is an artifact and intraluminal collection. So when you do a neutral end compression, you notice that this artificial intraluminal debris is too much to bear. And therefore, we confirmed indeed that this is a loose plastic. Here you could see that laminar structure already appreciated and seen on the ultrasound. So this was not really like a dislocation, but simply wear and tear of the polyethylene lining of the failed prosthesis in this case. And again, in vitro, confirming one more time what we were seeing in vivo in these individuals. The painful postoperative hip in somebody with cord decompression or screws removed or fibular, if you wish, grafts in these individuals are very helpful. Here on MR, you could see the retained tracks in this individual, surrounding fluid around the area, but it's readily more probably seen that we could look at this changes in this individual with a kidney transplant around the region. So kidney transplant, fibular grafting, avascular necrosis, what is going on with the right hip? Now, the artifacts-laden MRI images is very difficult to see, but once it developed fever and pain, we could again have a baseline radiograph go into the more complicated or very complex interpretation of MR. But very simply for us, because we don't have an open magnet yet, again, immediate confirmation of the fluid collection between the acetabulum and femur and a distension. Note that it is a failed graft because of the fluid accumulating outside it, and therefore very simply for us to sample the region, and if it's sterile, we know that maybe it is disengaging and some of the graft material outside of the femoral neck versus culture if there's going to be positive changes. In this case, it turned out to be gram-positive cocci. So, very nice perspective and orientation on MR, confirmation on ultrasound, and definitely sampling by ultrasound. Again, the patient needed a post-operative, as you could see, changes here in this individual, and of course he went on to have a hip replacement later on. Once in a while we encounter cases like this wherein we're sure that the pain is secondary to this prosthesis. We warned you, while it's very easy to approach the hip portion, the intra-articular portion, that it is not uncommon that something else is going to occur extra-articular or distally. So what are we looking here? Are we looking at a failed prosthesis? Are we looking at a secondary tumefactive changes in this individual, like sarcoma, or is it simply loosening? So we begin to look first at the baseline radiographs. Cone down views shows you that at the very end of the tip of the prosthesis you have this cauliflower, frightening appearance, spiculated lesion. And that's what we're going to address. Therefore, it's unnecessary to go to the acetabular portion. On ultrasound, again, the horn-like cauliflower type of appearance persists. But even more interesting is the fluid collection in this individual, and again perforating the cortex of the femur. First on CT, the low attenuation corresponds to the echolucent abnormality. Here you see the horns of the cortical remodeling that we already appreciated on the radiographs, and one more time on ultrasound, but again re-demonstrated on CT. But also on CT you could see inside more high-level attenuation that could represent some debris. Not to forget that we'd like to use MR, and in MR you'll see there's a fluid collection, but again you have extraneous material occurring well within this interluminal portion. What was important about all the additive modalities we had to the baseline radiograph is that we're showing that there's no soft tissue extension. That indeed the source was coming from the intramedullary portion of the femur, presumably from the indwelling prosthesis. So here we already saw it on ultrasound, on short axis view, and now let's look at it on real-time imaging. On real-time imaging, you can now see that there is the continued cortical shield of the femur, but as we proceed further down, now we're going to see the abnormal collection of fluid in these individuals. So we're still looking at infection versus inflammation. And as you could tell now, as we switch, there's this needle coming in. Notice that the bevel is down and that we are approaching just the fluid, but then we could sample whatever areas we need. Here, a little bit of possibly air introduced by us, or maybe part of the debris that we were sampling. Case in point, though, we're telling you that we are going to sample it easily with ultrasound. And going around, we scoot and sample not only the fluid, but also some of the soft tissues. When we do that, what we collect are these flake-like, whitish substances that look like a pseudo-abscess to us. But yet, when you do histologies in these individuals, you'll notice that this collection against the backdrop of some leukocytes definitely tells you that this is particle disease. So what happens? The failed prosthesis was trickling down and exuding towards the distal portion, and the prosthesis itself completely failed. And here, if you wish, you see this tumefactive changes representing an implant wear that was seen on ultrasound as a collection of fluid, clearly sampled immediately on ultrasound under needle guidance, and on MR telling us the different intensities present. But it's not until we see it and sample with ultrasound that we confirm that this was particle disease mimicking a tumor. So, in conclusion, therefore, get to know the technique and the anatomy of the hip in order to have an easy time in facilitating your exploration of the hip. And the different indications of effusion, bursitis, trauma, and prosthesis you are now familiar with, and so with that, therefore, I think one should be able to do a good ultrasound examination of the adult hip. Thank you so much for your attention, and I had a great time being with you today.